Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am really looking forward to a great conversation with Dr. Scott Province, who's been practicing dentistry in Manhattan since 1998. Dr. Province obtained his DDS from The Ohio State University in 1993 and served as a captain in the U.S. Army Dental Corps from 1993 to 1998, during which time he was stationed in Germany with deployments to Bosnia and Hungary, as well as humanitarian missions to Moldova and Mali. He is an alumnus of the Pankey Institute and is a member of the American Academy of Dental Sleep Medicine. Dr. Province is a founding member of the New York City Airway Study Club and is a peer-to-peer speaker with Candid Aligners, focusing on etiology and treatment of malocclusion using an expansive aligner technique. Dr. Province recently completed the 5-part Doc Phase 1 Archwire Development course, and he's already been implementing some of those techniques that he learned into his practice. So I'm really looking forward to chatting with him some more about that today as well. And one of the main reasons why I wanted to have Dr. Province on the show was to just talk to a wet-fingered dentist who's been doing this for over a couple decades, going on 30 years now, just to give some feedback to our audience. I hear so many questions from you all the time, and I love the questions and the emails and the feedback about kind of feeling isolated or unsure how to implement some of this stuff into your practice that we talk about regarding early treatment and airway. And as obviously it can be a very heated debate that happens between us as colleagues, and sometimes people get intimidated by that. As I also talk a lot about on the show, it's oftentimes difficult to change the way you're doing things. It's easy just to kind of get in your own pattern. Just do things the way you've always done them, and change is hard. And I want to give him credit for always being someone who has tried to change and push that envelope to improve the quality of care that he can provide to his patients and improve his practice as a result. So I know that his stories are going to resonate with others and motivate and inspire others to do a lot of what he was able to do. So with that, I would like to extend a sincere welcome to Dr. Scott Province to the Doc Podcast. Welcome to the show, Scott.
Thank you, Mike. Thank you for having me on this show. You have some great guests, so I feel kind of honored to be in their presence for this. And before we get started, I do want to say that I am a big podcaster. I've been listening to podcasts for 10 years now. Mm-hmm. And what I really love about your podcast is that it's not just about teeth and airway. It's a well-rounded podcast. You have health and wellness. You have finance. You got motivational Mondays, you just got a lot to it that kind of keeps it interesting,
Thank
and
you.
The other thing I really love about it, one more thing before we get started, is that I noticed, I think you brought this up, talking to Dr. Singh, that all of the clinicians that come onto your show, they all have this aha moment or this moment of clarity where kind of the dots get connected of underdevelopment and malocclusion and sleep disordered breathing. Now, some of them, like yourself and Ben Moralia and others, learn it the hard way. You're in the clinic, it happens, and then you see it. Others like myself, we hear you, or we hear Ben, or we hear Kevin Boyd. We hear someone talk about it. And for some reason, it clicks, it sinks in, and for me, it was very profound. And it happened a couple of years ago, which we'll talk about in my story. But I really had to go through stages with that, and the first stage really was almost denial, because I couldn't believe what I was hearing, that This is developmental and teeth and breathing. But then you look at through anthropology, you go back to McNamara, and it becomes very clear that it's real. So that was the first stage. Okay, I accept this. And the second stage was anger. Like, I was angry at my profession. I felt that we have been dropping the ball a long time, and specifically orthodontists. Now, not the orthodontists of today, because I feel they're doing what they've been taught to do, and they're doing to the best of their ability. But the orthodontists from yesterday, where they made a shift to extraction, orthodontics, and all that good stuff, that's kind of where my anger was. But now I'm at the third phase of acceptance. So it is what it is, and it took this long, almost 2.5 years, for me to actually have a conversation about it without getting overly emotional or angry, right? So that's where I am now. I'm at acceptance, and I'm very, very happy to be able to share, my experience with you. So here we go.
Thank you
I
so
had to
much
get that
for
out, Mike. Sorry.
no, I genuinely appreciate the kind words, and I love doing this. I absolutely love it. I wouldn't talk or meet someone like you. I love interacting with the guests. I love sharing it, and the feedback I get from people, and I have such a wide audience now that it's everyone from laypersons, and I have parents reach out to me and say, "Hey, this kind of sounds like my kid," or residents who hear some what I do on the financial side, and they want advice on looking at what practices they're going to look at, and I just love it. I love doing it, and I really appreciate the kind words that it's
Yeah.
well received and can inspire and motivate someone like yourself, because that's why I do it.
Yeah, good stuff. I'm enjoying it.
Well, thank you. So on that journey, and I love the stages of sort of grief, so to speak, of this, because it's so profound and so true and so common. I can't tell you how many times I hear people I coach, work with, or when I lecture come up to me after and say exactly what you just said, which is really why I wanted to have you on and talk about your journey, because it resonates with so many people out there. I literally just did a coaching call with somebody a couple of days ago. Actually, in this case, it was an orthodontist, and had the exact same discussion that we're having right now. So we're all isolated out there. And when I was in my little bubble in my practice, I knew what I was doing. I knew it worked. I knew I was seeing amazing things happen. But then you go out and you talk to others, and there is a lot of hate and sort of arrows that get slung here. And so talk to me a little bit about going all the way back, kind of when you came out. Thank you for your service, by the way.
You're welcome.
As
You're
well.
Welcome.
When you came out of the service and you went into practice, from then until now, so 98 until now, so 26 years, give a little synopsis of your journey as a clinician and how that's brought you to where you are now.
Okay. Well, I got out of the Army in 98, moved to New York City, and I started practicing, in a fee-for-service practice. I was very fortunate. I met David Zadek, a general dentist, a very good general dentist, who kind of taught me the ropes of being a real-world dentist, a real-life dentist. I was in dental school and then the Army, so it wasn't quite real life. Okay. And so, but after about 5 years of working with David, I decided to kind of go on my own. So Cinco de Mayo, 2003, I had my 48 patients. I leased an operatory in an office at 42nd and Madison in New York City. And I just started seeing patients and my own patients. And I did everything. I did the exams, the x-rays, the cleanings. So after about a year, I had enough patients to hire a hygienist. And so I rented another operatory. And so I had 2 operatories going a couple days a week. And it was then, though, that I started to see my work wasn't quite as predictable as I thought it should be. Now that it was my own practice, I felt there was a little bit more accountability, needed to what was going on. And so I started down the Pankey route. I took all the Pankey curriculum courses I could, and I learned a lot. I took a Dawson occlusion course. And so for the next 5 years, I just kind of built my practice, in the city, and I had enough patients at that point to build, I guess you call it your dream practice. And I did that at 49th in Madison, where I am now. And I opened that in 2012. And right away, I hired an associate. So I had an associate, a hygienist, myself, and things were moving along. And right now, still the same office. I have 2 associates. One's full-time, Dr. Debbie Schub, who's an amazing dentist, and Dr. Daniel Eidman, a newer dentist, and he's part-time, and he's learning the ropes. His dad's a dentist, and he's doing very well. So that was kind of like what was going on, in my life. And, a successful practice in Manhattan, it's a different place to work than most cities. A good friend of mine came to my office opening. It was really funny. And we left and we're walking to my apartment, and he looked at me and said, he goes, "Scott, this is a beautiful practice." He goes, "But how are your patients going to find you?" I was on the 8th floor. Like,
I always do wonder that about New York City. I really do.
There's probably 6 dentists in my building alone. We're everywhere. People find us, thank goodness. So that's that. So, successful, we're doing well. Someone asked me, how do you have a successful practice in Manhattan? And I said, well, for me, it was 2 things. Number one, it was accountability. Like I said, be accountable to what you're doing. And then two is treat the patients like you want to be treated. There's no waiting in the waiting room. We walk them to the operatory. We give them a warm towel after treatment's finished, all that good stuff. So we really try to go above and beyond. And I think that's kind of what is kind of the secret of our success. But about 3 years ago, I bought an Atero scanner.
Okay.
And I started scanning everybody, and I started to notice that there was a lot of crowding, a lot of malocclusion, if you will. So I started doing a lot.
Adult patients?
Just adult patients. Yeah. So to backtrack, I was only seeing adults. I never wanted children in my practice.
Oh, interesting. Okay.
Not even maybe the waiting room. My practice is an adult practice. It almost looks like an adoption agency to a kid, to a child. So I'm like, I wouldn't bring him here. So, So doing a lot of Atero scanning. In the meantime, I'd gotten married in 2012, and we moved to Montclair, New Jersey. We had 2 children, Jake and Danny. And Jake is going to be 12 this month and next week, and Danny just turned 8. So I'm just seeing adults, doing all that. I'm doing the scans on adults and doing a lot more Invisalign and all that. Your basic Invisalign with a little IPR here and IPR there, and getting those teeth straight. So I thought that was what I needed to do. Straight teeth last longer. But my son came in, and that's when everything flipped. I scanned him, and when we do the slideshow at the end, I have a scan of Jake.
Yeah, I'm looking forward to seeing that. So how old was this when
he was? About 9.5, almost 10.
Okay.
And it was bad. He had like a 10 millimeter overjet, class 2. And I was just floored. I had no idea what was happening because the primary teeth looked fine. So I reached out to a few colleagues, and they said, don't worry about it. We'll take care of that during ortho. I'm like, yeah, well, I don't know, because I had a pretty big overjet going into dental school, and I had my upper bicuspids pulled and, retraction. My bite looks great. Everyone compliments my teeth and my smile, but I have severe sleep apnea, severe. So, CPAP or MAD. So I was just like, I don't want this for my son. And how, can this be avoided? So I did what a lot of humans do when they have dental or medical questions. I consulted the internet.
Dr. Google.
I just started looking around, and I think I told you in one of our conversations, I found myself at the Invisalign CE portal, on their website. And there happened to be a video by Ben Moralia, one of your prior guests.
Yep.
And it was, the title was like Expand Out of the Daily Grind, something like that. And I never even heard the word expand in dentistry before. So I opened it, watched it, and literally, Mike, within 10 minutes, like my life changed.
Yeah,
like
you had that,
he connected the dots.
That was your aha moment. Yeah.
He connected the dots of underdevelopment of the jaws, malocclusion, sleep disorder breathing, and he did it with a child. And that's when my jaw dropped, because the child that he had shown was very similar to my son, and my son has always been sweating at night, tossing and turning. It looked like there'd been a party in his bed. The blankets everywhere, all that.
Yep.
So it hit me. It's like, whoa! So this is my son. So that was the turning point for me, and it was intense and profound. And I went to Airway Health Solutions, where Ben runs the curriculum, and I took all of his courses. The pediatrics. I took one with Kevin Boyd. 0 to 6, treating 0 to 6. So I took a full years of courses with them. And then Barry Raphael, integrative orthodontist here in Montclair, New Jersey, a wonderful guy, clinician, took one of his courses, and all of this massive information coming at me, and I didn't know really what to do with it. So I made
it's hard to filter through all that. Yeah.
So I made a PowerPoint. I just started making a PowerPoint presentation and using my patients that I had in the examples of what I was talking about, as far as lack of forward growth, lack of transverse growth. And so I put this together, and I would show patients, and I would show all my specialists. I would bring them in for, a lunch and just go over it with them. And none of them had really actually heard of it before. Even my oral surgeons, just never, periodontists. They're like, wow.
And this is just, you're talking like a few years ago, because if your son was 9 then, he's 12 now. We're not talking a long time ago.
No. I put this thing together, and and I just started showing everybody. And there's a saying in the movie business, don't talk about making a movie, make a movie, right?
Mhm.
So I had to stop talking about what I was looking at and doing and what I knew could be done for kids and adults. And I put some signs up in my office, and I put all the books in my waiting room, Eat, Sleep, Breathe, Thrive by Shireen Lim, and Breathe and Jaws and all of them, and Gas by Michael Gelb, which is a great book. And I put the signs up in each operatory that has the child and all the symptoms, and that's how it started. And parents would bring it up they would look at the sign and they would start having the conversation with me. And I've been very fortunate because I've been with these patients for 20 years, some of them. And so they trust me. And so they're going to trust me with their child. And it just so happened at the same time, I had put my son into some development and got him myofunctional therapy and got him, tongue tie release with Dr. Scott Siegel, the oral surgeon in the city. And so I was treating my child exactly how I was offering to treat their children, but I wasn't treating their children for their sleep issues, even though they had them. I just said, their sleep issues are probably connected to the underdevelopment of their jaws and the tongue space and probably some nasal resistance. So if we can develop that upper jaw, we can, improve their breathing, which will probably improve their sleep, which will probably, help with these symptoms. And they're like,
that's such a great point, Scott. Sorry to interrupt, but I want to just make sure everybody hears what you just said there. And that is, you didn't go at this to treat sleep-related breathing disorders or treat obstructive sleep apnea or diagnose airway issues. You're treating the malocclusion. And that is something that I just wish we could get everybody to understand, is that people who take this approach, the debate should really be, how do you decide to treat the malocclusion? It should be more of an academic debate. I can't believe we're actually debating over whether we treat the malocclusion at an age when we know that malocclusion is causing this patient significant issues, even if those issues were social, right? I mean, we still say, we see a kid who's kind of got, doesn't look good, maybe getting teased in school. Well, we'll wait until they're 12, 13 and do something about it. Well, there's serious consequences sometimes to waiting psychosocially for that child. So I think I just wanted to stop there to make sure everybody is aware of the fact that what you just said is what everybody with whom I speak on this topic says and is clear about. And that is, you're doing this to treat the malocclusion. So sorry to interrupt.
Right. Yeah, no,
but I thought that was really important to highlight that.
Yeah, thank you. I appreciate that. And so they say, wow, this is great. Is this new? And I'm like, well, it's been around since about 1890. You know what I mean? So,
a couple of years old. Yeah.
Right.
Newish.
So that's exactly how it started, and that's one avenue that I would, treat a child. And the other avenue is I would, if I'm talking to them about their own malocclusion and their own crowding, and we start connecting it to their breathing and their sleeping, they'll look at me and say, well, what about my son? Can we treat my son and hopefully prevent some of this? And that's the other avenue. Yeah. So it's, one of those two ways. And I have specialists now that do send me patients, like they'll send me their children, whether they're, grown or young, which is nice. That's a compliment.
That's quite a compliment. Yeah,
it really is. And so that's kind of how it started, Mike. And I think I told you it's been a couple years now, 2.5 years, and I have some pediatric patients that are in mid-treatment and adult patients who are in some expansive technique aligner therapy mid-treatment. So it's been good. It's been good. It's been a good journey.
That's really, really great. And I honestly, thank you for sharing that. One of the things I want to highlight is that you were going along, you were just doing this. You were practicing.
Yeah.
You were successful. You were, by every measure, doing what most dentists would dream of, right? Have their own practice in an area they want to be in. In your case, Midtown Manhattan. Would it be called? I guess, 49th.
Midtown,
you'd still be Midtown. And so, you're in that area, you're succeeding, and yet you were willing to look at your work and say something is missing. And one other thing you mentioned when we had spoken prior, when you and I first started talking a little ways back, was about what you were seeing happening in your restorative cases and in your adult patients and the breakdown that you were seeing in their malocclusion. And coming from a family of dentists, many of whom were general practitioners, my father and uncles have mentioned this many times in the conversations of this, just these broken down cases. And it really, if they had ortho, it didn't mean they weren't broken down. These denticians were so handicapped later in life and the associated TMD issues. And I'm not saying that orthodontics is causing these things. What I'm saying is it clearly didn't stop it from happening later in life. And right. You can't debate that. If there's a patient who had orthodontic treatment when they were young and they have these issues later, then you can definitively say that the orthodontic treatment didn't prevent it, right? So right. That's different than saying it caused it. But the point is you were critically evaluating these patients, thinking about it, and not just saying, I'm just going to restore this and do the best we can. And not even saying, well, let's go get them some ortho as an adult, which maybe you did or didn't recommend. But you actually took it one step further. And that is, I've got to get at why they are here. So was that part an aha moment too, in looking at your adult patients, or was that just something over the years that was kind of constantly in the back of your mind that you just didn't understand?
Well, I definitely had no idea why what was happening was happening. I knew, and I learned through Pankey and Dawson how to, make sure we had, lateral excursions and protrusive excursion protection and all that. I knew that. Mm-hmm. And so I really kept to that as part of my treatment modality and making sure when I did restore a case that they had those things. Mm. But I didn't have any real understanding of why my patients were bruxing, why they were breaking posterior crowns. I had no idea about, the lingual inclination of the upper teeth and lingual inclination of the lower teeth and how those horizontal forces are going to create, problems. Mm-hmm. I had no idea. And I had no idea why they were bruxing or clenching. I made a lot of very nice bite splints, custom made. Yep. Every 6 months they'd come in and I'd polish off the grooves, which it was protecting their teeth, but it certainly wasn't going at the cause of why they were bruxing. And my little slide
treating the symptom. Yeah.
I treated the symptoms forever until about 2.5 years ago. Mm-hmm. So yes, to answer your question, I had really no idea. And I think maybe we were taught at some point everything that we're talking about, even I remember at Ohio State, Dr. Melfi taught us dental anthropology, and I'm pretty sure the subject of diet and lack of, the diet had a profound effect on jaw development. I'm sure it was said, but there was no context to it.
Yeah.
There was no context. So we hear certain things, and as dentists, and it doesn't always stick. Because like you said, we're in the grind, we're in it, and it's a very difficult transition to go from not wanting children to walk into your office to hoping that every one of your adult patients will bring their child in for a screening, right?
There's so much credit for that. That is so much harder than a lot of people realize to change that.
It isn't. So again, though, it goes back to context.
I mean, more from like a systems perspective and a staff training perspective and a visit duration perspective, all of those little things that having run a practice, those are the things that go in my head instantly. It's like, oh my gosh, changing systematization to accommodate that. And I really think, I hate to say it, but I think that's a reason, and I'm not even saying it's not a valid reason. I just think that's a reason a lot of people don't want to do it. I mean, it's not super easy. So if you could elaborate a little more, how did you just kind of flip a switch and tell your team, like, this is what we're doing? Or was it you just started seeing a patient here and there and then said, well, if I'm going to see this type of patient, I've got to change my schedule this way or train my staff to deal with a younger patient this way? Because I think a lot of people get stuck there. If you have questions about a clinical case, or maybe a challenging practice management issue, or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice, Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
Well, since we don't have a ton of children coming in, maybe one a day, maybe two a day, but usually not more than that. And we've always treated patients one at a time, so I never really had to worry about, scheduling. They just get an hour block for their first visit where we do their diagnostics and, meet and greet and all that. And then they come back for delivery of the appliances. And in the past, it was generally fixed expanders. Now it's going to be a little bit different, which we'll talk about. So it wasn't a huge transition. I don't work multiple chairs. I have one chair for me, and my hygienist has, they have their chairs, and my associate has his chair. So we have 4 operatories. Not a big, huge practice. They're big operatories, but it's not a huge practice. So it wasn't overly difficult from that standpoint. An hour block is an hour block. Now, I was very fortunate that my office manager, Esmeralda, was an orthodontic assistant for many years.
Oh, neat. Okay.
So she really has helped me along the way quite a bit with the wet finger part of it, putting the expanders in. I remember the first expander I put in, my hands were a little shaky. There's no, I mean, they were. But the second one, no big deal. But the first one, I'm like, should I be doing this? And that's another thing. My whole career, I've always stayed in my path. I don't do root canals. I don't do third molar extractions. I don't place implants. I have specialists all around me in New York City that do those procedures way better than I can. So that's where they're going to go. So for me to step off my path and treat a child and start doing this phase 1 orthodontics on them was a huge leap for me. But again, there's some context to that as well. And that is that I have a son who was struggling that I didn't even know, and I wanted to help him. So I was going to do this no matter what. Now, my patients have been with me forever, like I said, 20 plus years, many of them. And so there's a certain amount of, obligation to want to help their children as well.
Yeah.
I knew that many of my patients before they got married, before they had children, and many of them have knew me before I had children. So, we're kind of all in this together. And if there were someone in my area, believe it or not, in Manhattan, I'm sure there are orthodontists that are doing this for children, but I don't hear about it. Like, I don't hear about them actually looking for it. Right. And I don't know if it's much their fault as it is maybe the pediatric dentists that are just not sending them when the children are 7 or when they're 6 or when they're 5, when they have sleeping issues. Because I don't know if they're really screening them appropriately for that.
Yeah, I think it's both. You're right. You're right on. It's all the above. It's the battle that we have ahead of us to try to improve education, improve awareness of this amongst our colleagues. And it is still goes back to the educational system, and we're just not learning this. We're just not. Very few places. I mean, I teach the residents at Nova about this, but there's not many places that the pediatric or orthodontic residents are getting a significant background in the sort of anthropological etiology of malocclusion, how that ties in, arch development, growth. We get the growth and development. We get the science part of it. Right. We can tell you how the patient grows, which is also what makes us so uniquely positioned to be the ones that address this, because we get so much in that craniofacial growth and development arena. Then we are okay with just relegating ourselves to just straightening teeth when we get out. It's like, maybe an expander here or there, or maybe a headgear here or there, whatever some people do, kind of quote unquote growth modification that we'll call it. But we seem to be very happy to just focus on tooth straightening. And we went through a lot more school and a lot more time and energy and resources to learn to do a lot more than just straighten teeth. And most orthodontists are going to come out of most programs and be plenty adept at tooth straightening, right? What differentiates you? It doesn't take 2 to 3 extra years beyond dental school to just become that proficient in straightening teeth. You can learn a lot of those techniques even sooner than that. What it takes that extra time is to really understand the growth and development, I feel. And unfortunately, in residencies, there's just so much time spent on the tooth straightening side, and so little time spent on the growth and development, that it isn't something they come out learning. And we tend to come out and practice like you were saying with you came out, you practiced, you had your sort of niche that you were in, and it's hard to see outside of that. And then you get busy. And as we said before, changing is hard. And it just kind of becomes this thing where I really don't look at the majority of people who don't do this and say, oh my gosh, like they're actively trying to not help these patients. Right. I actually look at it and say, and I'm not saying you are, I'm just saying my own opinion, is more like just kind of, they're a little bit naive to the fact that this is even a thing. And because honestly, Scott, I've never talked to a colleague who has done this or been on the journey you've been on or that I've been on and has said, yeah, I that wasn't much fun, changing the lives of these children and improving the quality of their life. Like that, right. That really doesn't do much for me. Most of us go into this profession, we're altruistic. We want to help people. Right. Yeah. We're providers. And so I know that was, as I've alluded to before on this show, and you touched a little on, that was sort of my landmark moment. My aha moment was, oh my gosh, I'm doing more for these kids than just like making space for their teeth, which is also great in and of itself, but I'm doing more than that. And have you felt that yet? Have you felt that just in the past couple of years, have you been able to really kind of get that visceral feeling that you're doing more for these kids?
100%. Yeah, it's happened. Almost every one of the children that I've started developing with, the hard way with expanders.
I'll talk a little about that, but yeah.
I have a case I'm going to show you. Just a couple sisters, and they came in pretty begrudgingly in the beginning. This was only a few months back, and literally within a month, both children are no longer grinding, no longer waking up in the middle of the night, and night terrors are gone. So that's just in like a month and a half or so of developing, insane. Just helping them breathe through their nose, helping them get restorative sleep,
So great.
And the reason why I really am passionate about this is because for a child, and this, for a child to grow cognitively, emotionally, and physically to their genetic potential, they have to have restorative sleep. And what does that look like? It looks like silent nasal breathing.
Yep.
That's what we want, right? And
it doesn't have to be obstructive sleep apnea.
No, it doesn't have to be that at all. And we know that, just an increase in negative pressure in the airway is enough to trigger the brain to go into sympathetic drive. And boom, they're in fragmented sleep. Just to stop that with as many children as I can is my goal, which I'll show you again on the slideshow. But that's it. I mean, but again, like you said, though, a lot of people are naive to this understanding, and I get it because I've been practicing for a long time, never once heard about this, right? So the pendulum is swinging because of people like you and people like Ben and Becca Backow and Bill Hang. I mean, it's swinging, it's changing, and it'll get there. But there has to be a way for general dentists to hear about this, because mine was just a stroke of luck. If I hadn't sat down at my desk when I did and went to where I went, I would have never had any idea about this. My son probably would have been on his way to having his upper bicuspids extracted.
Without a doubt.
Right? And it shouldn't be that way. It shouldn't be that way. So, and I think it's easier for a dentist like myself who's been doing it for a long time and who has seen the consequences of what's been happening to children for the last 90 years, meaning the 12-year-old, 13-year-old braces, making that upper jaw even more narrow in some cases, right? Reducing the tongue space. So they can't even keep the tongue up north. It falls down. They're never going to wear their retainers from the ages of 14 to 26 or whatever. By the time they're out of college, their teeth are already crowded again. That's why they come to see me when they get out of college and they can afford to get them fixed. So they've never had the opportunity to even, they were never even told to keep their tongue to the roof of their mouth. So, muscles of mastication, collapsing that upper jaw, creating the crowding on the lower teeth. I mean, it's just, so the context is that I see that. I've seen what happens. And so if I can go further upstream and prevent that, then I'm going to help the next generation of general dentists that are seeing those patients. Hopefully.
Completely.
Right?
And one of the reasons, again, I wanted to have you on and talk about this is because the orthodontists, we don't get to see the patient later unless they happen to break a retainer a couple years down the road, or we maybe we'll see them in public or in the community, but we don't examine them, and they're no longer our active patient once they're kind of dismissed on their nights only, wear your retainers to bed protocol. So the general dentist keeps seeing them, and I have spoken with so many general dentists who started to have their aha moment when they're like, wait a minute, I was told that if you just waited and pulled teeth on this child, that it didn't have negative consequences, right? And what I'm hearing you say is a lot of the patients that had tooth extraction, again, and speaking empirically, right? Your 26 years of clinical experience counts for a lot. That's, again, Peter Attia, I say it a lot, but his sort of evidence-based versus evidence-informed. That is evidence-informed. You have seen thousands of patients, treated thousands of patients, and that gives you the authority to make assumptions and assertions based on your experiences. So looking at your experiences of those patients where we're told, and orthodontists, there's many orthodontists who get up there and say all the time that there's zero negative consequences and effects of extracting teeth on a patient who is narrow, that you don't want to expand them if they don't have a posterior crossbite, if they have restricted arches, even if those arches are narrow, if they don't have a posterior crossbite, you don't expand that patient. And this is not just a couple people thinking this. This is actually dogma within the profession by and large. You don't expand that patient. You set them up to remove tooth mass, right? Because they don't have room for their tooth mass. You have to extract it because that's the only way it will be stable. Is if you pull teeth on that patient, the only way you can get a stable, functional occlusion is to extract teeth. So that's kind of that's the traditional orthodoxy within orthodontics. Tell me what you see in terms of those cases that we don't get to see, that we can make the models sit on a table or spin around in a 3D and look really, really good, like nice class 1 overbite overjet, right? Maybe not always, even in some of those cases, but let's say we are. What do you see 10, 20, 30 years down the road in that patient's life and in their mouth?
Well, I rarely see a patient come in who's had 4 bicuspids extracted where they're not now in some type of malocclusion, whether it's crowding or whether it's a crossbite relapse.
Interesting.
But I have seen them. I have them. They're there. A couple of cases I'm going to show you later. One of them is a upper bi extraction, and you'll see it's not good. He has right side crossbite, and he's in traumatic occlusion on his front 2 teeth, and he wants to have his crowns replaced, but there's already bone loss around one of them or both of them, and I can't do anything with that until I fix that occlusion, right?
Yep.
So it from my experience, it doesn't matter if they've had orthodontics or they haven't. Most of my patients come in with traumatic occlusion, and it's usually in the anterior. It's the wear of the anterior teeth, obviously due to bruxism, but it's there, and their jaw wants to be forward, and it's trapped.
Yep.
So
yep.
Unfortunately,
so is it fair to say that you tend to see patients? Would it be fair to say you see a certain number, but you do see a number of patients that have, and I've never asked you this question, so any of these questions, but that had 4 bi extraction and come in as an adult, a little bit class 2-ish, maybe kind of end on deep, 80, 100% deep, upright incisors, obtuse interincisal angle, broken down anterior teeth and attrition, and worn off cusps. Is that something it's fair to say you've seen a time or two?
Fair to say. You see it all the time.
Yeah.
I would find it fascinating if an orthodontist got to see 100 other cases 25 years later.
Such a good point.
Let's look at a photo album, it would be interesting to see that, because they may want to think, they would probably think a little differently about what's happening, but then you could easily blame it to not wearing the retainers. Everything just kind of collapsed in and went back.
But we're told, I understand what you're saying, but we're told that if you expand and grow those arches young, that's not stable. But by extracting teeth and treating to the perimeter or the width of that alveolus that you're given, right? That what you're presented with, you can't change that. That is what is supposed to confer stability. Little and Rydell had a ton of studies on that. And their studies, if you look at them, are actually not very good at all in terms of the controls and the standardization of the duration of treatment, time of treatment, treatment objectives, who treated the case, the type of retention, anyway. But that's what we are taught. That's what I was taught, is that the best way to treat a patient is to treat to the arch form you're given, the arch shape you're given, and make the teeth fit, which if you do that, you're pretty much forced to take out teeth. There's really not much of a way to do that otherwise. So, and we're told that is the most stable. But, you just made me think of something, Scott, and it's such a great point when you said about 25 years out, have to sit and look at those cases. Where are those studies, right? All the people who say that, there are enough studies to say you should be treating these kids younger and expanding and doing all this. I've gone through on this show many times the studies that do lend credence to that. But where are the studies that orthodontists look at these cases 20, 30, 40 years later and look at the breakdown in the periodontium and the breakdown of the dentition, the periodontium, the overall health, the parafunctional habits that these patients now have? I think that's something we need to call for.
That's the point. Yeah. So is it stable? Maybe it is stable in a vacuum. But the patient's not living in a vacuum, right? There's too many different forces coming at them, and the biggest one is, we know lack of tongue space, right? Collapsing due to muscle activity, and then bruxism due to airway restriction generally, most often. So maybe in a vacuum it's stable, but in the real world it's not stable, and I see that. So it's interesting you brought that up about, expansion and it not being stable and causing all kinds of problems. Well, if you develop them at the right age, right, and you make the maxilla wider and then you upright the lower molars to match that bite, so you're definitely going to be able to go more than the 3 or 4 millimeters that generally kids get. Say you get some bone loss in the back. Say eventually they're 25 or 30 years old and there's a little bone loss and a little bit of recession, but they've got ample tongue room and they've been healthy breathers for a long time. Well, if they just get general orthodontics without any development, they're going to end up with bone loss and recession anyway. And I know because I see it every day. So the question is, what do you want? Do you want the ability to breathe with some bone loss, or do you want the inability to breathe with some bone loss? I'll take the breathing and the bone loss. So, and that's another thing. I see tons and tons, or I have seen tons and tons of bone loss and recession. And it didn't matter whether they wore braces or not, right? So why is it that they have all of? So I brought this up to an orthodontist once, and he said to me, he said, that's because there's still too many teeth in the mouth.
Wait.
I go, what? He goes, there's not enough room. That's why there's so much bone loss, because there's just not enough room. The teeth are crowded. It's putting force on the bone, and you're having bone loss. I'm like, well, okay. So he basically said more teeth out is better because there's more room for the teeth, which I understand, but that's not taking into account all the consequences associated with, lack of tongue room and all that. So, but now
and you can tip the teeth too far. One of the things people criticize people who have more of an expansion philosophy is, and of course, I again kind of give this disclaimer, but I understand you can tip teeth too far out of the buccal bone, especially in older patients. In the late, you can tip them too far labially, cause dehiscence, again, recession, loss of attachment. I get all that. I've practiced a lot of years, and I understand the biological parameters. That being said, that goes again both ways. If you remove too much tooth mass, the only way to close space is constrict, right? I mean, it's the converse of making space by expanding, right? You increase width, you increase perimeter, and this doesn't have to be teeth. This is with anything. You decrease width, you ultimately are going to decrease perimeter if you don't want any spacing between the objects you're lining up, in this case, teeth. So if you just continue removing more tooth mass and you have to close that space, right? You can't close it by moving like the entire anterior dentition posteriorly, or the entire can try to move the entire posterior anteriorly, but even with TADS or anchorage or all those things, there's always some anchorage loss. So you then are in a position where you have tipped the teeth, the anterior teeth lingually and the posterior teeth lingually off the bases of the bone. Right. And so why is that somehow okay? Right? That's okay, but tipping them a little more buccally or a little more labially is all of a sudden like you're deeming this patient to a life of occlusal breakdown and failure.
Yeah, right. Well, I asked him, why he feels this way, and he said when he was a resident, he really tried to save as many teeth as he could. He really felt that was the right way. And he goes, but his director, who he trusted, had said to him, he's seen it all. He goes, you just got to get teeth out if you're going to put him in a stable position. Yeah. So he had the initial thought of trying to save, but his mentor, who he trusted, got him to go the other way, which
that's the dogma.
Yeah, right. And it's a tooth focused dogma, right?
Yeah, so, You're not even looking at, and it's a symptom focused dogma, right. And it's medicine 2.0, as Peter Attia talks about it, right? It's the treating the symptom position and stance that our medical system is caught in, is reactivity and treating the system, and he calls on us to move towards medicine 3.0. And I've said many times we need to move towards dentistry / or specifically orthodontia 3.0, which is, let's get at this earlier. Let's get at this before we have to try to treat the breakdown, treat the symptoms that have come. So on that, if you would like, maybe that's a kind of a good segue into orthodontia 3.0 and going at this earlier in a way that you weren't trained to do. And initially you've gone through a lot of education on that, and we'll kind of talk through it. So if you want, I think you should be good. So those who are on audio only, this would be a point at which you'd want to kick over and maybe mark it to hop over to YouTube, to the doc community on YouTube, and be able to watch. I'll put links to the video in the audio as well, so you can hop over and watch some of the video that Scott's going to be sharing with us.
There we go. Can you see that, Mike?
I can. Yeah.
Great. So I do. I said, as you said earlier, I lecture for Candid peer-to-peer type of stuff, just to kind of talk about expansive technique. And I always squeeze in etiology. So I think I've spoken 2 or 3 times, or 3 or 4 times, and maybe to about 50 dentists at this point. And so I always, like I said, I try to just kind of plant the seed and kind of like get to the etiology or the reason why we're there to even treat the adults. So, I always start with this slide, which is kind of, I guess 5 years ago or 4 years ago, I would have looked at this and it wouldn't have made sense to me, but now it does, because it's all connected, right? We know that. And then let's see, go down to this next slide. And, I like to point out that the airway is not an independent unit. It's really dependent upon the growth of the jaws, forward and then transverse.
Craniofacial respiratory complex with Kevin Boyd.
Kevin Boyd right there.
Yep, just had Kevin on. Yeah. So, great.
So this is a loaded slide here. And this basically shows, ancestral man with 32 teeth and big palate. And then it shows a myriad of different malocclusions, right? And we know, if you believe in evolution, 3 million years, give or take, to get to the DNA we have. And over the last 450 years, give or take, we've developed this malocclusion issue, right? Now, genetically, if we were to go from 0% of a population to 50% or greater, which I would assume we could say as far as the prevalence of malocclusion, it would take 13,000 years, give or take. So
interesting.
We've done, and that's a ballpark, and that's probably a low ballpark.
Yeah. Yep.
So we know that this is all developmental. We do, and I know what Dr. Singh, it's very complicated, but the basics of it are, as you've said, many times, it's our lack of nursing, our soft diet, right? Our mouth breathing, right? Those are the main culprits in soft tissue dysfunction, why we have such malocclusion. But I have a question for you. Maybe you can answer is, so those are the things we call malocclusion, right? But what about the lack of room for third molars and third molars not coming in to occlusion? Wouldn't that be considered malocclusion as well? And if that were the case, it's a lot more than 90%, right? Very few people have room for their third molars. If they do, they are not really wide enough transverse. They're usually very narrow, and they are forward. The AP is good, but not the transverse. So
they've essentially become vestigial. But are they vestigial because of an evolutionary process, or again, that's what we tend to get taught? Oh, third molars because our jaw sizes are just changing as we've evolved. Well, are they, or are the jaw sizes becoming diminutive in a sense because of what is causing that? Is it really just the genetics of evolution and time, or is it the environment? And I don't know how people, the anthropological data so strongly support that.
Yes,
that
right. Coracini, Rose, they all say the same thing. That our diet is the major influence of why we don't have bigger jaws, which is fine, right? And so I always say, I think that there's an unintended consequence to not having room for 32 teeth. And that unintended consequence is sleep disorder breathing. And if you listen to Mike Mew and a bunch of other people, it's an epidemic that's throughout all civilized world. And so and then I'd like to say, if we don't have room in our mouth for our teeth, we certainly don't have room in our mouth for our tongue. So, and you've talked about this in many of your podcasts, that the tongue space is important because the more narrow the airway, and as airflow goes down the airway, if it gets smaller, it creates a negative pressure. Very similar to when you turn on the shower head, the shower curtain gets sucked in. That's happening in our airway. But the problem is, it doesn't need to be snoring or sleep apnea for that negative pressure to trigger the brain. As soon as it triggers the brain, there's a sympathetic response, because the brain knows there's a problem in the airway, right? That sympathetic response releases adrenaline and cortisol, leads to bruxism and systemic inflammation and all those things. So I always really hammer that point, that it doesn't have to be snoring or sleep apnea. It just has to be that increase in negative pressure. And then, as you know, there's that pull, that vacuum pull from the gut, which is silent acid reflux, and I see it in so many of my adult patients, and I see it in the children as well. Right. And that also just re-inflames adenoids and tonsils. So, you talk about collaborative care all the time, and how important it is that not just the ENT treat the child, but some clinician that understands this growth and development situation to kind of finish the puzzle. Right. So the reason why I bring this up is because in my practice, or in any general practice, everything that we treat, almost everything, except maybe periodontal disease, right? I mean, you could say that, but pretty much everything goes back to this underdiagnosed and untreated growth and development, right? Everything, crowding, chipping, wearing, fractures, abfractions, recession, it all goes back. So I didn't know that, and many general dentists don't know that.
Sure. Many
But
orthodontists aren't aware of that. Yeah.
yeah, so this is why, what I've learned over the last 3 years has changed my general practice with my adults. And then I see this; these are all my patients, and I see this every day.
Yep.
So here's the problem. So you have this knowledge, you understand now where it's coming from, why your patients, it's like the post office in a general practice, just so you know. I mean, it's always something. My patients come in, they're like, I come in every 6 months, I brush, I floss. I go, but they say it's always something. And I'm like, well, now I can kind of walk them through that it's not what they're doing when they're awake usually. It's what's happening when they're sleeping. And it doesn't just have to be bruxism, there's silent acid reflux. And so now I have to re-educate my patients because I've probably educated them wrongly for the last 20 years because I had no idea.
And that's another obstacle that a lot of people face I was just talking to a resident yesterday about this, that it's really, really hard when you've been telling your patients and your team and everybody all this time that this is the reason for something, or this is why we do something, to go to them and say, I actually think I've been wrong about this, or at least not 100% right. And that takes a lot of humility and a lot of courage and a lot of confidence in yourself to be able to do that. And a lot of people, I know from talking to people, they're just not willing to admit that. And so again, kudos to you for that. And that's such an important thing, because so many people are a little intimidated to have to face that reality.
Yeah. Yeah, I get it. And then, so the change really came, once the change started in my practice, I had to kind of reinvent how we were approaching them as far as what our discussions were going to be about. So now we have a new smile and airway self-assessment that all our patients will fill out when they're in the hygiene room waiting, for me to come in. And so I can have that to the side and be able to look at that, and it'll kind of help me guide the conversation, right? Yep. So the goal, like at the top says, dental crisis office, to dental healthcare office. So in the past, we fixed what we had to fix and did what we had to do. Now we're trying to, just kind of, re-engage them in a different way, so that we can kind of get to the root of why they're having these problems. And I do a lot of expansive, aligner therapy now for patients that are not willing to go, if they've got a huge maxillary mandibular discrepancy and they need a MARPI SARPI dome, I will refer them out. And over the last couple of years, I've had 2 go forward with that, and 1 who actually did orthodontic surgery. But all stimulated by our conversations and some of the diagnostic tools that I use in my practice, which will be CBCT and rhinometry, which I'll show you here in a second. So it's changed the way we treat patients. So this is a case I'm in the middle of right now, and she's been a patient for 20 years, give or take. And just, you can see number 9 is I had a root canal, and there's some darkness there, and she's been to the endodontist, and they can't do an internal bleaching because of the proximity to the facial wall of the tooth there. So we're going to have to do a crown there to really camouflage the dark tooth. But the problem is, if you look at the iTero scan, is that she's in traumatic occlusion. So she's hitting very hard on her front 4 teeth, harder on her front 4 teeth than most of her posterior teeth, right? So
with upright incisors and an obtuse interincisal angle. And for those who are listening still and haven't switched over to watch it on video, it's a 49-year-old female with prior ortho, history of prior ortho, TMD symptoms, and bruxing.
Right. And so in the past, I probably would have just done the crown for her.
Okay.
But but I know her symptoms, and I can see her CBCT, and while her airway isn't terribly small, her tongue space is gone. There's no tongue space, and you can see that, and it's pushing on the soft palate. So, that's where her bruxism is coming from, and her TMD is coming from the fact that she is pretty much locked back. So her condyle is in the fossa to an area too far back. So I'm going to go at this in a different way. And so the next slide just shows to the left is her present upper arch, and her right photo there shows that we're going to widen the upper arch a few millimeters, but we're also going to slowly just bring 6 through 11 forward a little bit.
Yeah.
Just a little.
Open that envelope up. Yep.
Yeah, just open it up. And, I tell my patients now that, space is your friend. We'll have some space, but we'll camouflage it if you want. Younger patients want it camouflaged. The older patients are fine with it.
Yep.
I have those little gaps back there behind the canines now. We call it the Province gap in my office.
Yeah. Love it. Yeah, so you tend to just kind of tuck that 3 to 4, putting the canine in the first buy, where it's not very visible. Yeah, absolutely.
Yep. And we can do a little camouflaging. It's not hard to put some composite back there.
Yep.
Right. And so now that once we develop the upper arch a little bit better and we have room for the crown, now we can actually do the crown. So for her and most of my adult patients now, I'll use an expansive aligner technique, right? Or I'll refer out, like I mentioned. And once we're finished with that, then we have to now make sure that we're addressing, the bruxism and make sure that she's not, in an airway issue. Okay. So I have a couple different things I do. I can do a passive mandibular anterior repositioning splint. So when the patient bites down, their lower jaw will move forward a little bit.
Sure.
And I have a ton of those out now. So the splint to the left is one of the acrylic splints I used to make. I don't make them anymore. And I've replaced a lot of them over the last couple of years with the new splint. And I just talk to patients and I let them know that, a vertical splint, when you bite down on it, your jaw is going to go in a clockwise fashion because your head's not going to go up, your jaw is going to go down and back a little bit. So the thicker that appliance is, the more likely you are to actually be making the problem worse. Now, not all patients are going to make their, airway restriction worse by wearing a vertical plane, but many will. So just to avoid that issue, I don't make that splint anymore. And if I can also, with her final set of aligners, I can do kind of a modified class 2 elastics just to kind of hold the bite in place. So her jaw is not going to fall back when she goes into restorative sleep, muscle paralysis. So that can work as well. We can do a home sleep test, and then from there we can figure out if we actually need to do an MAD or a CPAP or surgery, right? So at that point, though, we'll go to a sleep physician if we need to. So that's just kind of real world treating, an adult patient in a general practice. They come in and they generally are not looking to have their airway fixed or to have their sleep fixed. They're coming in for their teeth, right? So you have to plant little seeds for many of them, and just start educating them, show them their CBCT, and then just talk about it, right? And as time goes on, if the seed starts to germinate and grow, then we have another conversation. Okay, here is that upper bicuspid extraction case I talked about earlier. So he still has that.
Everyone out there, please take the time to go look at the video, because this is exactly what I'm talking about all the time.
Right.
There is no way that treating to that arch form, if you got to treat this kid as a child, whoever doing the ortho, pulling those upper bis, to leave a maxilla like that, I just don't know. And where's the evidence base for that, to leave somebody with that great of a deficiency in the transverse, especially in the anterior middle third?
Right. You never, and I really, like I said, I'm at a point where, acceptance. I don't know how old this patient was when he really had this. I don't know how he presented. So I don't really know what the orthodontist had to work with. But
the etiology wasn't addressed comprehensively. That's for sure.
Right. And this was not stable. And you can just see the severe bone loss on number 9.
Oh yeah.
Right. Yeah. And 24. So what am I going to do here? Well, I'm certainly not going to replace those crowns in that situation. He's not going to go for surgery. He said it. He's not doing MARPI, SARPI, or DOME. He's not doing it. So I'm going to have to do a slow, expansive technique with aligners and just get his bite to where it's not hitting so traumatically, and it'll get there. And they're always, we always go over the possibility of of maybe further bone loss, maybe even loss of teeth, but that's never happened. I've never had that. And I always explain the difference between putting fixed braces on at this age and trying to expand compared to using aligners, are two different animals. The aligners work off of pressure tension, teasing the bone and slowly getting some deposition. So generally the complications, I haven't had any. And in 20 years, I've had one patient have loss of attachment on an lower anterior tooth. And that was because he changed the tray out every week. He didn't go every 2 weeks. So he accelerated the process, the attachment loss. And so, we sent him off to the periodontist. He had it taken care of, but that's one time in 20 some years. Okay. So we'll get into to my son's case here, but this is, we talked about earlier, this is my goal is to just kind of prevent the sleep disorder breathing in children that potentially we can stop in adults.
Yep.
And here was the slide that changed everything for me. This is my son. That got me going. And then here's Jake. This was Jake. This is a few years old, but you could see, and this is a great case because if you look at his airway, that's a pre-op airway. That's a big airway.
Yeah, right? That's pre-op. Wow. Yeah.
Yeah. Healthy. But
yeah.
And I say this to patients all the time, we don't diagnose by pictures. We diagnose by pictures and symptoms. We have to put the puzzle together and then see what's what. And so for Jake, literally that expansion that you see, Mike, I gave him, I think, almost 8 millimeters there.
Yeah.
He stopped sweating within a couple of weeks. It didn't take long, and he's been a healthy little sleeper ever since. He's a good sleeper. He's a boy, boys can be a boy. But
look at the difference in the eyes, Scott. I mean, my goodness, and that face in the beginning, the appearance of his face in the beginning is the classic face you see from kids who aren't getting restful sleep.
Right. 100%.
And I, again, be clear to everybody, I'm not saying that face means that kid always needs expansion, right? Like sleep issues are multifactorial. We don't understand them. We don't know exactly what's causing them. I'm going to have Audrey Yoon on shortly after you, and we're going to dive a lot more into that side of things, but it's still an unknown science. Right. But it is not unknown that when you have a patient like that and they do have a transverse deficiency and you help them grow, you so often get the patient, virtually almost all the time, get the patient on the right side of the screen, which is your son, after he had been sleeping well. And it's just, when you show people that, and I show cases like that, and some people still don't want to engage that concept, but I'm like, if you treat patients like that, it changes you. It really does. And in this case, your own child. It's just so profound.
Right. I agree. And so this is me. That's my airway.
Interesting. Yeah. Look at the narrowness there in that oropharyngeal area.
Oh, look at the indicator line, so I know, listen, and you said this before, the orthodontist in dental school, I had my bias taken out of dental school. He didn't cause this problem, but he didn't help it.
Right. That's well said.
I had an airway issue. I had a 10 millimeter overjet. I had a tongue, I have a tongue tie. I had allergies as a kid. I was a mouth breather, all low tongue resting posture. So I developed a class 2 with an overjet. So the airway issue was already there. But
again, you've said so many great points, and I apologize for interrupting, but I want to highlight that, make sure it gets noticed. He didn't cause this issue, but he didn't address it or fix it. He didn't improve it. And that is something that I'll come up against all the time with colleagues who are like, extractions don't cause airway problems. I'm like, I never said they did. Like, what I'm saying is there was an underlying problem, and by not doing anything about it, you missed the opportunity to improve it. It's a totally different discussion.
Yes, totally different. Right. And it'll change. It's just going to take some time.
No, it will.
Oh, these are recent photos.
Oh,
so
wow.
That look at that arch. It's
look
crazy,
at the stability.
Right?
Beautiful. Yeah. And look at the smile, the eyes. Oh, so great.
I just did for Jake. I did upper lower fixed expansion, and I did some candid aligners. That's it. So now we're waiting for the rest of his permanent teeth to come in, and we'll do one final go around with the aligners, and
he'll be set. And another thing on the screen, if people are just listening, one other big myth that I hear about a lot is if you do this young, the adult teeth don't come in wide. They still come in narrow. Or if you upright on the lower arch and help expand the alveolus on the lower arch, those teeth still come in narrow. I have done this thousands and thousands of times. I've coached people, taught people, guided people through it. It's simply not true. It is simply not True. Maybe if you don't do it correctly, right? Maybe if you, yeah, I don't know, if you don't do the
Right.
expansion properly or have the right approach, sure. If you don't do anything properly, you're probably not going to get a great result short or long term. But if you do it properly, looking at your son in those pictures that you have now with the width of those arches, and those premolars erupted beautifully. Those canines erupted beautifully. And that's another thing in their literature. They talk about, well, you can't expand canines, you can't expand intercanine width, and it's not stable. And all the studies are based off of permanent canines that have already erupted. And I'm like, it
Yeah.
is a totally different discussion when you talk
Right.
about expanding prior to that. Neil Kravitz, who's a well-known name in the orthodontic arena, and just using his own words, I know he's not a fan of the early treatment and going in more aggressively early. He's actually got an article in 2014, I think it was, in the journal Clinical Orthodontics, where he used an Arnold expander and talked about how the earlier you do it, the better, because if you get at it before, I shouldn't say the earlier, the better. If you do it prior to, it's important to do it prior to the eruption of the permanent canines, because if you wait for the permanent canines, then you're going to have less stability, but you want to expand it first so that the permanent canines can erupt wider. So even some of the people who are against this philosophy have put stuff out there in the past that shows that it works. So again, it needs to be, I think, highlighted just how nicely those teeth erupted after you did what you did.
Thank you. And then, okay, so real quickly, this is little Ellie, and one of my first sleep disorder breathing patients, and mom brought her in because she saw the sign, been a patient forever, headaches, stomach aches, morning moodiness, all that. You can see her, her Bolton standard, she's growing down and back. And what was great about Ellie was that she has two siblings, and mom brought them all in. So you got to see what was going on. And so Sean to the left, Ellie in the middle, and Emma to the right. Emma's only a little small because she has a congenitally missing lateral, but both siblings were nasal breathers, but Ellie was not. So mom saw this, and she just couldn't believe it. She just couldn't believe what she was seeing, right? So we got her right into treatment, and I got to show the mom my CBCT, and we learned a couple of things. I learned through Kevin Boyd as far as the adenoids and posterior nasal spine, and I look at the indicator line just to show mom some of the numbers that show that Ellie's growing in more of a clockwise fashion and not a forward fashion. And then I obviously talk about the transverse. Right? We know what the transverse measurement should be, and then we give her a little treatment plan, and the ENT is always involved, especially if there's mouth breathing. I like to cover my bases on that. And then we get into development, myofunctional therapy, very important. And then MyoBrace or, Healthy Start, whatever you want to use, or Vivos, and then potentially liner therapy. So for Ellie, I use the upper and lower fixed expanders. And, it talks here on the screen about the major changes that happen when you do that. And that's really what it's about. It's the increase in nasal passages. It's the increase in the nasopharyngeal space, the dropping of the soft palate, right, and the movement of the jaw forward with the tongue. Just creates this big space for the child to actually breathe. And so this was really like 6 months into treatment.
Oh, look at
you
that.
You can just see the
eyes, the
balancing of the face. She's no longer, lower third deficient. So really cool to see that. So, between these, she's one of my early ones. So between her and my son, I was just off to the races. I didn't want to stop.
It doesn't take much once you see it.
No, you just see it. You're right. It happens quickly.
You can't unsee it. It's like
So two little sisters, these are the ones that came in not too happy. And then you can see the older sister breathing with her mouth a lot, and you can see the growth going down and back. You can see she's more restricted with the CBCT. Right. I forgot to go up here to the top. This is Ellie using rhinometry.
Rhinometry, sure.
Yep. And
so Karen Parker Davidson on a little while back, and we talked quite a bit about that in an episode.
Right.
Yeah.
So this is measures the nasal passages and nasopharyngeal space, and it always increases or at least balances out. The weak gets stronger, the stronger kind of balance down a little bit, and it happens in the passages and it happens in the nasopharyngeal space. So I can objectively at least offer something. We know through back out studies that adenoids and tonsils kind of decrease in size with proper development. So, there's studies out there that show that there's an improvement in the airway. This is an objective measurement that shows that there's some changes happening physically in there. And now we know why. By using something like this and using CBCT, we can really show the patients what's going on, So it's almost medically undefensible to not be doing this.
Yeah,
personally.
fair statement.
So here they are now, but this is going to be interesting. So real quickly, eyes started to change. The smile got bigger.
Yep.
And then this is what's great. So this is their questionnaire, grinding, night terrors, all that stuff. And then literally just a month or two later,
look at that.
We're getting lots of ones. Mom's super
This
happy.
is filled out by mom.
Yeah, totally. And I forgot to even talk about it because I just forgot. And the mom just goes, "Did we tell you that they're sleeping through the night again? They're sleeping through the night now, and their terrors are not having these night terrors so much." And they're both daughters. So now the younger one, actually, I took her upper expander just came out, and she's coming back in 2 weeks. I'm putting the brackets on her. I'm getting the. I have to transition her out of that, out of those the fixed ones at her age, because she's young enough to where we can do that.
Yep.
And so, and here's a case that we just did together.
Yeah.
And she had expanders in, Mike, and you were going to ask about the pitfalls of doing what I'm doing and what are the challenges. Okay, so I work really hard at doing a really good workup. I take all the necessary, diagnostic information. I make a PowerPoint. I really go out, and I present it to the parents, and the parents are like, "Let's do this."
Yeah.
So the patient, they come back 2 weeks later. I've got their 3 weeks. I have the expanders ready. I go to put them in. The child is not loving it. It's hard. Yeah. Now, when they're over 11, it's no big deal because they're generally mature enough to let me do that, and I can get some expansion and I can get some, brackets on them if I need to, and it's no big deal. But when they're between the ages of 7 and 10, it's not working for me, and it really has held me back a little bit. And I got
very hard on them, like you said. It's very hard on them.
It is hard on them. So I got very fortunate, and I'm going to say this. I saw you talk, and my first gut was, okay, another orthodontist pushing brackets and wires. I go, that's why we're in this problem in the first place.
That's fair.
But I knew that I couldn't be narrow-minded. First of all, because you were talking about the airway. So that was right there. You had me. But then you started showing some cases, and I started to see the development of the arches with these little wires and brackets. And I'm like, yeah, that's what I want. But I don't like putting braces on. I just don't like doing it. But I knew I had to do this. So last week I had a patient come in, and what did I do? I put him on. And I got to tell you, it was the most pleasurable experience I've had with a child so far.
Yeah.
It was easy. They sat there. I had the little, cheek retractors in, and I got it done, Now for her, I still have to add those back ones in, but
and that's okay.
She's going to be great. But look at the CBCT up in the upper right. Look at the canines. So one of the things I love about doing early bracket and wire like you're teaching is that I'm not going to worry about those canines so much right now.
Yes.
I was worried with the expanders. I was wondering, was I going to get that space?
Yep.
But now I know that I'm going to get a better anterior 1/3 development using this technique. So I'm very happy to do it and excited that I took your course. I'm not plugging it because I'm on your podcast.
I appreciate it. Yeah, no, it's much
really
appreciated, the kind words, and you did a good job on those laterals. I see they're nicely tipped, a little extra distal there to not run them into those canines. A mistake I made early in doing this many years ago that I had to learn the hard way of. Thankfully, I never damaged a lateral root, but there were a couple times it was a little closer than I liked. But once you tip those out, those are usually those lateral roots are going to tip in mesially beautifully. And again, by bonding the upper canines, you're going to develop that bone and that alveolus. The traditional ortho phenomenon, but the cure-all articles are when you see those canines like that at this age, you want to extract CNH.
Right.
Well, that what you're doing is if you don't give the canine space, and 6 and 11 don't have space, as we call them, the threes in orthodontic lingo, but then they don't have anywhere to go necessarily. So by going in and using the primary canine to develop the alveolus and help with the expansion, one of the best parts about archwire expansion, and again, the point of this isn't to promote that side of it. I appreciate your kind words, but I think it's really important to note that I got so much better expansion in the anterior and middle thirds, which is oftentimes where you really need it in these
Right.
cases. Whereas with the expanders, even though the science and the literature a lot of times says you get that triangle, that the base of the triangle is toward the front, and the apex is toward the back, I found that if they start kind of with a narrow V-shaped arch, they kind of ended up with a turnkey expander with a wide V-shaped arch.
Right.
Whereas this just lets you develop them anteriorly, and I'm so excited for you to see. Wait, first visit, she's going to come in and you're going to look and just go, no way that just happened that quickly.
Right.
And then it just gets more and more fun. And your other comment on it being fun, that is so true. I did a lot of upper and lower expanders. I mean, thousands. And I saw probably just about everything you could imagine with them in my time doing them. And they work. They're better than going in and extracting teeth and not addressing the etiology of the transverse deficiency. But man, I never had one kid say, I wish I had those expanders. I would have kids like, I tell my friend, you need to see Dr. because he doesn't do expanders in younger kids. And I mean, the kids, they love it. They have fun with it. I never marketed it. I never advertised it. I just literally started doing it. And once people heard that was something I was offering, it just kind of just grew from there. So yeah. But again, your MO is you're willing to push the envelope. I give you so much credit for, you're not trained in bracket placement in that regard, but even though you're not, took my courses, you learned it, you understood it, you asked me some follow-up questions, and this is a great job. I mean, you did an absolutely awesome job there, and now you're just going to get to see the magic happen, so to speak, as she continues to come back.
I hope so. That upper left scan is great too, because you can see that she's, adenoids are way inflamed. You can see that her right nasal passage has, the turbinates are highly inflamed, right?
Yes.
Mom saw this, and we had our talk about what's going on here, and she'd already seen an ENT, but the ENT wasn't concerned, so she's getting a new ENT.
Yeah, and that's a big problem. It's hard to find some of these providers, but you have to keep persisting. You have to keep seeking them out. Parents will drive. Once the parents understand that this is their kids' well-being, they will drive to find the right providers. Or in your case, maybe take a subway, a couple other extra stations to get to a place that will get them the care they need. So was she reported to be mouth breathing, snoring, all of that as well?
Yeah. Hasn't been a great sleeper. You can just kind of tell. You can see it.
Those eyes. Oh my gosh.
But she's a lovely girl. She's gonna get healthier.
Yeah. And on that too, one other thing, the underdevelopment of her maxillary sinuses is really profound. And that's something you see too. If you don't breathe through your nose, those sinuses don't develop. Kevin talked about that's the air is the functional matrix of the nasal passageways and sinuses, and they're not developing. They are not developing.
So we're hoping that we get some improvement there. And then, obviously, the consequences of fragment sleep for children is pretty catastrophic, especially for a growing brain. And then obviously with adults, if we don't, talk about it with them and get them sleeping healthy, that a release of adrenaline and cortisol all night long leads to chronic inflammation, which is, related to a ton of comorbidities, right? Over 150, comorbidities are directly. So super important. And I remember when I first started, I was so obsessed, and I'm thinking, all right, Scott, give it a break. It's malocclusion, whatever. But then, there's more important things out there, in the medical field. But then I realized that, well, this is related to so many of them, right? We have to address this early. And, if we do, we're going to certainly change the lives of these children. And in doing that, we may even, have a profound effect on their adult life. Because, they say, show me an unhealthy kid and I'll show you an unhealthy adult.
Yeah.
So, I know you asked a question about how does someone like myself do this? And I was very fortunate. I was educated through Airway Health Solutions. I'll plug them because they're amazing. I
Ben and Lauren.
Ben and Lauren.
Yep. Awesome.
Lauren always says, be the change you want to see.
Yep.
And that's kind of what I'm doing. And yourself with your course, that's given me another, tool in my arsenal to treat children at a little younger age without having to put fixed expanders in. So, I feel very fortunate. I found the right people. There's this, the saying, the teacher appears when the student's ready.
Right?
And I was ready, and thank goodness I was coasting into retirement. I'm almost 60, but now I'm kind of like, are you kidding me? I want to keep doing this. This is just a lot of fun, and it's so helpful. And
That's so awesome. What in
Good stuff.
closing, kind of wrapping up, what would you say to the orthodontists or general practitioners or pediatric dentists? What would you say to the ones who still feel that there's not enough evidence to do this, or that you're not really helping the patient, or it's empirical? I mean, what, as someone who is in this, has gone through quite a journey, but is in the middle of this still, what would you say to the people that don't think what you're doing is actually doing what you're saying it is?
Well, it's difficult to change someone's perspective because they have a lot of confirmation bias, whether it's the research that they read or whether it's a Facebook chat that they get involved in and they hear what they want to hear.
Yeah.
Like I said, if you're not ready, you're not ready. But if you think this might be something that you want to pursue and you're a dentist, well, treat one of your employees' children, or maybe look at your own child a little differently, right? And that's a good starting point to see if maybe this is something that you want to do, or that you can do, and if you see it making changes, right?
Yep.
But it takes a little leap of faith. But to be honest with you, Mike, I don't know how you could not do this once you've learned about it. Like the moment I learned about the etiology of all of my adult dental issues that I've been treating for 26 years, the moment I learned that, I knew that I had to do something about it.
Yeah.
Now, if I had a child, would I have started treating children? I don't know. I don't know. Maybe I would have gone more intensely into, MARPI, SARPI and all that, and working with adults. But because I have a child and it means so much to me, I'm just wired now to help children, So that's what I'm doing next. Is I'm opening a practice in Montclair, New Jersey, 1 day a week, starting in September. Just like I started in Manhattan 1 day a week, or by myself. I have a nice office to work in, and I'm going to just start seeing children. And the next phase is to actually learn, probably through you, how to actually start up an orthodontic type of system. I don't know how to do that. I just know how to do an adult system. So I have to learn a little bit there. But 1 day a week, we'll see where it goes, and if it starts to pick up, which I'm assuming it will, then I'll pull 2 days and 1 day less in the city.
Yeah.
So that's kind of my goal.
Just so great. I mean, first of all, for the orthodontists out there listening, who still kind of hold on to this, like, well, the GP should be doing ortho and the pediatric dentist should be doing ortho.
Wait a minute. Maybe I shouldn't be. Maybe I shouldn't be, but I'm doing it because no one else is doing it.
Thank you.
You know what I mean? I don't really want to do this. I like doing it because I like to take myself out of my comfort zone a little bit, and I like what I'm doing for children, but I shouldn't have to do this.
Yeah. Thank you.
I shouldn't have to see these children. They're not being treated.
Yeah.
So I'm sorry.
Please don't. That is, I'm glad. I was literally going to say that, and it's much better it came from you, because me, it's like, he's got this platform and he's always kind of saying that. And I get it. I can kind of sound like a broken record, but I say that to my colleagues, Stacy Becker and I have talked about that many times on the show. And that is, Stacy says the same thing. She's like, I can make a lot more money going and putting a pound on an implant.
Not even close. Right. She's so right.
Yeah. She's like managing a little kiddo that I'm not necessarily like trained to do, and doing ortho that I wasn't trained to do. She's like, but I can't not do this for these kids. Now that I know it's a problem, and now that I know kids are suffering.
Right. She's so right. Yes.
Yeah.
Yes. You have to.
It's just like,
right.
Yeah. So coming from you, that means even more. And the orthos that think that they can just sit back and rest on their laurels and say, no, I'm going to be dogmatic and say, we've always done it this way. This is the right way to do it. You got to wake up, because
I have a practice full of adult patients that are going to tell you, that'll show you that what you're doing is not as predictable as you think it is.
Yeah.
For whatever reason.
Yeah.
There's many reasons.
Yep.
But it's not predictable. It's not sustainable. Otherwise, Invisalign wouldn't be around.
Great point. And it's one of those things that's kind of a tipping point. It's right now we're just kind of escalating. It's my financial advisor calls these things like a hockey stick, right? You kind of gliding, then you start to turn up a little. And I think that's where we are now. And as the public catches on, as more people like yourself are doing this, as more people start to hear these messages, as more residents come out, that people such as myself and Audrey and Rebecca and people are teaching, you're going to see it turn. And the ones who aren't the ones who aren't in line with this philosophy are going to get left behind. And because we're not stopping, we're not waiting. We're not going to let these kids suffer and just sit there and wait for some 20-year randomized control trial that we can try to prove this to please some of the academicians, of which I am one in my capacity now. But so I'm certainly not knocking them, but that's where we're at. And so right. You can jump on this now and expand your reality a little bit and start to do what you did. And just to conclude, I really want to acknowledge you for what you've done. I mean, Jake's a lucky guy to have you as his dad. And he, as someone who looked at him and wasn't willing to just say, you know what, go to the local orthodontist who's going to do this because that's just what they do. And you've changed his life and you are changing the lives of other patients. And that is what this is about. That's why I'm so passionate about it. That's why I'm doing this. I just, your story just fills me with excitement and joy because it shows me that there's a lot of hope out there. And I get caught up a lot of times in battles with people that are, really hating on this, and being the fighter I am, I kind of want to fight it. And then it's so good for me to have this discussion to be like, don't waste my time and energy too much. I'm not going to change those minds. I've got to focus on people like yourself, people who want to help patients and really make a difference and a change in this world, more than just the way they were taught. So I give you so much credit for all you've done to change, and you minimize it. You kind of act like it's nothing. You're humble about it, but I'm telling you, I know how it is to totally change, especially at this point in your career. And I just give you a lot of credit for it. And I thank you for sharing it so openly and honestly with the audience. I really do.
Thanks, Mike. I appreciate that. All the kind words. I really do. Yeah. And it's my pleasure. And I'm just, like I said, I'm fortunate that I have people around me like you that could help guide me, right? And you and Ben, I mean, without you guys as mentors in my life, I can't do this because I wouldn't know what to do, right? Yeah. But I know what to do now. And I know that if I don't know what to do, I know where I can go. Yep. I know where I can reach out to, but maybe eventually general dentists won't really have to do this as much. Maybe it'll be the pediatric dentists and the orthodontists. But until then, like you said, we got to fight the fight and keep moving on and try to make a difference.
I love it. Perfectly said. I'm going to end with that. I can't thank you enough. Anything you need, you let me know, and they're happy to help you in your journey any way I can.
Thanks, Mike. Appreciate it.
All right, Scott. Thanks so much.
Have a great weekend.
Right, you too. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.